Hi, good morning, everyone. Thank you so much for attending our session. We're going to talk about our journey through systemization. Before we get into that, we'll just do a quick introduction. So Sam Herold, I'm a senior manager for clinical engineering for the Yale New Haven Health System. I have operational oversight over half of our delivery networks, but also sit on our capital planning committee. And I've been with the health system for 7.5 years.
Hey, my name is Ryan Schafer, also senior manager in clinical engineering. I have day-to-day oversight at Bridgeport Hospital and a lot of our subspecialty services that we're going to talk about today. And looking forward to talking to you guys today about all the work we've done the past year or two.
So just a disclaimer, we're not going to come up here and say that we have it all figured out. There's a lot of our staff members in the audience who will definitely call us out on our BS. But what we hope that you gain from this presentation is that there are actionable things that you can take back to your organizations to kind of start small and help in that standardization journey. Definitely feel free to write down your questions. We'll take questions at the answer. But really, this is what worked for us. Whatever you take back and apply it to your lives and your careers, we're happy to help you be a part of your journey as well. So a little bit about Yale New Haven Health. So geographically, we're located along the the southern border of Connecticut, ranging all the way from New York up through Rhode Island. We do have 5 different delivery networks, but really it's 7 different hospitals. There are several of these hospitals that are multi-campus, so it covers a wide variety. Ryan will talk a little bit more about our ambulatory locations, but we have over 300 ambulatory locations that our in-house teams also support. We have proximity to New York City at our Greenwich Hospital, up in the New London and Westerly area. We're close to the Connecticut, the sub base, the Coast Guard Academy. So there's just a lot of different activities in this this southern corridor of Connecticut, and we are the largest health system in the 3rd smallest state. So that's a fun fact that we should put on a T-shirt, maybe. But we do have 2,600 beds. And all of this is supported by a team of about 53 technicians with an additional 20 ancillary support staff and over 67,000 pieces of medical equipment. So really our journey started with quality. So we had a lot of staff at a lot of different delivery networks, a lot of different care spaces, that ambulatory space, our inpatient space, and everyone was doing something different. We had a combination of in-house and outsourced resources at those different sites. Everyone followed a different MEMP. We had different policies and procedures. And even at those campuses that are under the same Joint Commission license in separate campuses, they were operating as 2 separate entire entities and hospitals following different MEMPs and procedures. So really our journey started about 5 years ago, so pre-COVID, but definitely expedited because of the pandemic. That we started with, the basic building blocks of just talking to each other, having more system-wide meetings. We have a clinical engineering operational safety huddle that is run on Tuesdays, where everyone just started talking to each other and figuring out, okay, like, what are you doing? How do you address this? Like, I have this issue. Has anyone else experienced this? No changes. Just, being curious and going at it with that curiosity and questioning attitude to learn about what other folks are doing. And then really 2 years ago is when we actually started to put plans together to make us actually become a system-wide department. We had those building blocks kind of started, and then it kind of grew from there. So with those building blocks in mind, similar to our healthcare organization, we put together a mission, vision, and values specifically for the clinical engineering department. Our vision really was that when you thought clinical engineering, I wanted our industry colleagues to think Yale New Haven Health. If you have a loved one who needed care, I wanted you to think, I want them to be seen at Yale New Haven Health. And I think HTM, we play an incredibly important role in the healthcare delivery for our care team, for our patients, the research teams that we all support. So we wanted to be that destination for healthcare as well as for HTM. So our mission was to support innovation and excellence in patient care at Yale New Haven Health by ensuring that we had safe and effective access to medical equipment for our care team to be able to care for our patients, which seems very basic, right? But this had never been formalized, had never been said out loud, even by teams who were doing great work. So being able to kind of have that guiding principle. And then, like I said, our vision was to deliver that best-in-class healthcare technology service for our patient. We wanted to demonstrate integrity, accountability, and teamwork. And then we had a couple of strategies that we pulled together, which really kind of informed our initiatives and what our foci were going to be moving forward. So that we wanted to have a standardized healthcare technology management program, one MEMP, one single MEMP. Even if you don't have a hyperbaric chamber at your site, it was getting rolled up through our singular MEMP. And that really, we talked about how our journey really started with quality, but a big component of it, and to get leadership buy-in, was to manage our service costs. And we would do that by developing deep technical expertise in our biomedical equipment technicians and our team of clinical engineers. So we really wanted to invest in the staff that were then going to be on site performing the actual work. We wanted to actually have a proactive life cycle management program. Basically, capital 5 years ago even was very retroactive, and I'm not going to say that it's perfect now, but we actually have a plan now. We project out 5 years, which we'll kind of talk about a little bit later on in the presentation. And then also, we would never be at those tables. We would never have seats at those tables without partnering with our clinical and operational teams. So really elevating our department to come out of the basement, although some of our sites aren't in the basement, lucky them, but really getting them out of, just kind of the break fix mode, which is the bread and butter, and we'll absolutely talk about how important that is, but really, elevating our team. And then, of course, talking about the clinical and operational efficiency through enhanced integrations between clinical equipment and information technology solutions. So at Yale, we do roll up through our IT department, which has created a lot of synergy in being able to get things done in that regard.
So we, excuse me, leaned on some of our DTS colleagues throughout the organization, and we have a really strong pillar structure. Us in clinical engineering, we're part of our care team experience pillar within the DTS organization, which is really how we drive operational efficiencies for all of our care teams. I think we play a huge part in that. We partner very closely with our Epic colleagues, all of our biomedical device integration colleagues, and we really create that structure, that workflow that helps us address some of those care team needs throughout the organization. So when we looked at our kind of vision for what our strategic assessment should be for what we want to do moving forward, we took 3 key pillars that we wanted to address. The first one, first and foremost, is really our cornerstone, which is our department operations. It was very fragmented, too much variability. No one knew how to get a hold of us. How am I calling here? We have a lot of staff, a lot of travelers. They travel between sites. How do I just get a hold of clinical engineering? It's a huge problem. If we can't communicate together, that's a huge problem for us. Then when they could communicate with us, they might get a different response based upon which delivery network they were at, who they were communicating with, and how they were communicating with them. Is a huge barrier for us to overcome. And then making sure that our teams, our technicians, our engineers are all collaborating, working together, and running on those same processes and protocols. Our second pillar was really, how do we dive deeper into specialized support? We really need to get out of our service contract entities. It's been a huge challenge for us, and we want to really get closer to home, support our teams better, support our teams closer to home, and really elevate, to Sam's point before, what the skill set of our teams are, right? We don't want to just be fixing the basics. We want to elevate our teams, create those specialty services, really provide them that career pathway to move up within the organization with those services. And then the last is our service line partnerships. We'll talk a lot more about that later in the deck, but it's really been important for us to really elevate ourselves, work very closely. Sam and I work very closely with the vice presidents, senior vice presidents, all the way up to the presidents of our hospitals to really address the needs of both our department and our service lines to have a collaborative approach for how we address the organization. And I think, it'd be remiss if we didn't say the bedrock of our team is really our techs, our engineers, our clinical systems engineers, and we have a lot of hybrid DTS clinical engineering roles that really help us get together here. We've been able to re-strategize, reprioritize, and kind of redeploy folks in our teams to really address our needs more effectively. And that couldn't have been done without a lot of the acceptance of how are we going to approach this differently. And I think everyone has really bought into that messaging throughout our department.
Yep, but you have to crawl before you can run, right? So it was super important that we got our basics right. And as I said before, there were teams who were already doing excellent, great work in pockets, and it wasn't consistent across the delivery network. And to Ryan's point, when people call clinical engineering, you may get 7 different responses, even from within the same department, because we didn't have any SOPs, we didn't have any guiding principles, we had nothing. So we really started there, which was building trust with a strong foundation. So that is being responsive. So if somebody calls you, they ask for escalation. Not only do you complete the job, but you close the loop with that person. Hey, this was done. Is everything good for you? Can I do anything else to support you? And once you kind of meet, it's like Maslow's hierarchy of needs, right? Like once you meet that basic functionality, you can continue to be collaborators and solution experts in that space, but you can't do that if they don't trust you to even fix, an auto-ophthalmoscope, right? But part of that too is that leadership, we needed to provide the right tools for our teams to complete the job. So we do have a standard CMMS across all 7 hospitals, including our ambulatory locations. And even before, we're going to talk about kind of our outsourcing to insourcing journey, even before we fully did that piece of the puzzle, we were taking a feed from that other CMMS system into ours. So at least we had a cohesive install base across all delivery networks. And then looking at, what else we needed to do to provide to our teams. So thinking about 4 different kind of functions of clinical engineering: capital planning, maintenance, both preventative, scheduled, and corrective, reactive, recalls and safety, and then our personnel development. So within those kind of 4 buckets of clinical engineering functions, we started to put together what procedures we needed to address those needs. So for example, in our capital planning bucket, we'd be like, oh, we don't have an asset disposition procedure. Like, how do people retire assets in our organization? So we would, start drafting that out. And, our recall management process, our recall team would work with 7 different people at the 7 different hospitals for all the same equipment and get 7 different responses to recalls. It really was kind of crazy and unwieldy to manage. So looking at, centralizing that role, so that, our recall team reaches out to one person from clinical engineering who coordinates our teams. For example, like our scheduled maintenance, like what was our could not locate process? I don't know what it was. We didn't have anything written down. So we started to, draft our procedures. We have a standard template. And now that we had that, these like structures to it, how do we actually move this through, get buy-in from the delivery networks and actually approve something? So it's a very painful democratic process, but we do have a team of super users, our subject matter experts, and our shared governance, which is our clinical engineering leadership team. So if somebody has a procedure that they want to input into one of those 4 functions, it starts with an idea, we start to draft it, our team of clinical engineers will draft that out, they'll run it by the super users. Does this make sense from a frontline user perspective, what we're asking you to do? It comes back a couple of revisions, blah, blah, blah. And then once they kind of pass and bless it, it goes to the shared governance group. So the leadership team, then we discuss it. Does this meet our needs in terms of regulatory compliance and reporting? And we go back and forth. We'll send back edits to that super user group. They'll send us back edits or questions, or like, we don't have, the necessary information we need to make this decision. And then that leadership team will vote in a democratic process. Do we approve this procedure to be rolled out or not? And then it kind of, goes back to the clinical departments that, yep, here's our could not locate process. This is what everyone is going to follow now. And that those processes and procedures are stored, of course, in a central location. Yes.
Do you have control to push those decisions to the whole? Like, do you own all 7 clinical engineering sets of components?
Between the 3 of us, yes.
Okay, so you actually have control to push those out. I was just imagining that much challenge.
Yes, and it was a challenge, and that's some of the reason we'll talk about, our outsourcing to insourcing journey. But there's another manager that works with us, and between the 3 of us, we do have, I don't like the word control, but we do have oversight over those technicians and the frontline staff.
Yeah, I think the only thing I'd add, Sam, is I think it's really just empowered our teams to really be a part of the process. I think that there was a time where the team is very disconnected from the management component of our structure. And I think empowering those teams to have the conversations on their own, come together, give their valuable feedback, bring that back to us, and really have that narrative, I think really changed their feeling of, engagement with us as leaders in the department and themselves as collaborators between our different delivery networks. We laughed the other day today. I mean, there's technicians that are just never going to meet each other with how geographically diverse they are, and just getting on the phone, coming to a conference like this, empowering them to come here. I think half of our staff is coming over the next 2 days. That wasn't really an opportunity in the past, and really creating those opportunities to bring that team together, I think is really important for us.
Absolutely.
With 67,000 pieces of equipment, do you have any RFID system that would be standardized throughout all these different facilities?
We do have a standard RFID solution. We use AeroScout. I'm not here to propone or be a proponent for opposition against. But we do utilize AeroScout system. We do have 2 separate systems of AeroScout, but everybody is utilizing the same thing. Our technicians have the ability to log in and look and track for equipment.
Still cannot locate issues?
Oh, yeah.
That's not on seal, so.
No.
And we don't have everything tagged either, right? I think we'd be remiss to say that. We tag very strategic assets. It's an unwieldy system to manage. It's standardized, it's systemized. That's great part. Yeah. Exactly. So I think there's a lot that is tagged. It's really our high use, high need, high availability devices, but we're not going to tag every vital signs machine, for example. So I think as we hit, one of our next pillars, I know we just talked about operations. It was really, what are our specialized strategic support shifts that we need to make here? Our key question that we asked ourselves, we sat down, we love to volunteer for our internal audit team to really validate, what we need to do, what we need to accomplish. And these were those 3 key gaps that we identified as a department. We go through this every year and we try to figure out, where do we need to improve? How can we get the support that we need? And what do we need to do there? And I think our rationale was really grounding ourselves in the mission, vision, and values that we brought to our team, right? This is what we want to do, and this is how we want to approach it. And we really wanted to get to the point of getting that strategic, standardized healthcare technology program so that we could really control and monitor that performance and really control our costs. I think a big thing for us over the past 2 years, and I think it's allowed us to validate the work that we do and really get us into a lot of the important rooms, especially with our finance and leadership folks, is we've been one of the few departments that has consistently, continuously improved and reduced and saved costs while still doing more with less. And it's an important part for our shift here as well. Our biggest gap that was identified for us, and I think we just acknowledged it and we wanted to kind of tackle that, was we wanted the entirety of clinical engineering services to be in-house at Yale New Haven Health. As a large academic medical center, we felt that it was very important for us to bring that need forward, to really elevate our teams, educate our staff, and really have that continuity of support across the network. At the time, before we started, we had 4 different third-party service agents on top of having a partial in-house program, which really led to a very siloed structure of who our teams are, how they operate. Even if they work together, they may not actually have to follow the same processes, do the same things, get calls the same ways. And I think that was a huge, A, financial impact for us, and B, regulatory impact for us. Not to say that, who we had working with us and for us was not doing what they needed to do, but we felt that there was risk to not having full control of that process to really address those needs in our organization. Our next high value item that we really wanted to address was our diagnostic imaging. I think close to 50 to 60% of our operating budget annually is on full service contracts for imaging. It's our highest point of contention. We had a huge discussion with our leaders within radiology. We said, this is the path we want to take. And because we had a lot of those key conversations, we had that support, we were able to start down this journey of building that in-house diagnostic imaging team. So we identify this as a high financial impact for us. And then I'd say low to medium regulatory impact. I think there was 2 things that we're trying to address there. It's, we're not very effectively tracking what's actually happening with some of our OEMs in the space, because we had and felt like we could trust those contracts. We had great relationships with all of our field service, and service reps, all those. But it was important for us to really bring that in-house, more effectively manage that, address those costs, and really identify those needs in the space. And then our last one is our ambulatory offsites, as Sam alluded to before. We have over 300 sites. We have 6 different business units within that. There is no standardization from our ambulatory structure today, which would be a good conversation for another year. But we had 3 third-party agents in that site as well. Financial impact for us was low. We really, it's low acuity equipment, low acuity spaces. We do have some big boxes out there that have surgical centers, et cetera. But the primary, there's our primary care center, specialty care centers, outpatient visits, et cetera, that we really want to make sure that we had control, we had that maintenance structure, and we need to address that. And again, with the regulatory impact of medium, a lot of our sites are not tied to any licensing. They're not tied to a joint commission requirements. They do have state DPH requirements, but there is a lot of variance out there that we've been trying to find a better way to address and provide those services. Yeah.
Regarding your third-party ambulatory offsite support, was that just kind of a matter of fact, kind of the way you grew up? Why did that structure get established? Was it a separate business?
From the,
that was
yeah.
and it was just kind of,
So I think it's as we've expanded.
able to do that kind of stuff, but
Right.
the shift to internalize it?
Yeah, so I think there's a multi-factor rationale for those gaps. I mean, we as a health system have grown. I mean, started with New Haven, and we slowly expanded to those 7 hospital structures. And at the same time, each of those delivery networks that we reference had their own offsite locations. And then we've also acquired other, ambulatory practices. We have Northeast Medical Group, we have Yale Medicine, which is an affiliate of the university. We've just acquired an urgent care practice, which we've just reformalized, which was formerly Physician One, and is now Yale New Haven Urgent Care. So there is a slew of, what were they doing before? Why did we never capture this? And quite honestly, we were never tasked, and many of our support services were tasked to support those spaces. I laugh when we jump on the call. I had a call this week with our ambulatory leaders. There's a Yale Medicine director, there's an NEMG director, and they all do the same job. So just trying to address that, and they're like, wow, it's really nice that clinical engineering is the first support service across the entire entity that is going to strategically prioritize us and our needs at that level. Second behind our IT team, because they leverage all of that from the financial, technical backbone. But we are, finding that structure very important for us, and it's getting us, into the right rooms, into those conversations.
That's familiar to me, and I think it's familiar to a lot of people that work in a growing and evolving organization. That we don't have that iterative process,
right,
to command and structure that centralized, standardized support model. So we kind of take what are you using right now? Okay, we'll continue with that until we get to some kind of prescriptive or predictive implementation strategy to be able to say, okay, this is how we're going to support.
Yeah, agreed.
Yeah, and 5 years ago, that was our strategy as well. Whatever was in place, we would just try to kind of manage it. And once we realized that we actually didn't have the influence that we needed or wanted, that's when we started to sort of make those shifts. But again, creating that trust and the building blocks that we were providing such great quality service in our delivery networks, that leadership now trusted us to kind of expand and branch out beyond those, the walls of the hospital.
So yeah, as a part of that assessment, I mean, ambulatory, I would call it at the end there, but approximately 25% of our assets that were owned by our organization were actually not managed by our internal resources. And we identified that as a huge gap for us. We wanted to make sure that we, A, fully knew what was happening in our fleet at all times. B, we knew exactly how those devices were being managed. And C, we really felt comfortable with how that strategy was going out from a capital perspective. When we look at our delivery networks here, we can see our structure. We had 3 in-house programs with our main 2 campuses, York Street and SRC in New Haven. Lawrence Memorial Wesley Hospital in-house. They were all on our CMMS Nivolo. And then we looked at Greenwich, Bridgeport, and our ambulatory programs. There was a slew of third-party. There was a slew of different CMMSs that we tried to aggregate data from. And in our ambulatory space, we actually did not know what we had in our fleet. There were some pockets where we had effective inventory, but I got a list from somebody, and they said, we don't know. We haven't heard, we haven't seen, we haven't audited the site since we first started. I was like, that was a huge concern for us, and we've grown proactively re-inventorying our sites ourselves with no additional resources, trying to find a way to do that and approach that while simultaneously servicing that fleet. It's proved to be a challenge, but I think it's proved that we can help meet a lot of the needs of the programs and have really driven our availability to our teams. So these were, what was identified to us, and again, we love volunteering for audits. Tell Sam and I where we can improve. We all know we're terrible at our jobs sometimes. I'm just kidding. And I think the last thing we saw costs continue to decrease with limited added value, right? Every time we get a contract renewal, the cost is going to go up. I think it's just a known thing, right? We work through it, we accept it, and we said, well, why can't we just do this ourselves? And I think that was an important thing. And thankfully, we had a lot of conversations at our senior level, and there was a buy-in for us to actually do that based upon what we have done, what we've supported, and what we continue to do here within the organization. So I think it was a long process. I say 18 months, but I think the genesis for the idea was really 24 months ago for when we started talking about that. When we did our insourcing for Bridgeport, Greenwich, and our ambulatory team, we pulled over 19 FTEs. We transitioned 51 contracts that were held by a variety of our third-party vendors. And then, I call out financial impact, but it really proves to us that this was the right thing for us for standardization's sake and for operational sake. We saved approximately $750,000 in the first, 10 months, 11 months in from our transition in January. And I think the best part of this regulatory value, everything that we own is now supported by us. It's supported by our technicians. It's managed by us. We have full access to the data. We have full access to the information. We have full access to determine the operations, procedures, processes that we want to address here as a team. I love to call it out because I think, Sam and I laugh about it. It was the smoothest transition that the president of Bridgeport Hospital claims to have ever seen. And that's what she called out to us at the senior leadership level. And it's really a testament to our teams and to the people that work on the site every day that was the level of visibility we got as a part of that transition. And that was communicated across the organization in our senior leadership groups, which I thought was, awesome. I think, the big thing for us was the concept preparation and planning, right? We have a huge business planning process, which I know we'll briefly touch about a little bit later, but just getting that forward, making the plan. We all know how hard it is to ask for more FTEs, especially when there's a fixed kind of capitated cost to it. So we said, hey, we can do this. This is what we need to do it. So what we need to accomplish it, and this is why we need to do it. That took us about 6 months to get through. Once we had that commitment that we were going to do that, we spent about I'll call it 3 months nicely, but it's probably 3 to 6 months transitioning 51 contracts. We have a huge collaboration with our corporate supply chain team. We meet bi-weekly. We work through that every single day for months. And big smile to Lauren over there for doing a lot of that work. And then we had a cutover planning and prep. I mean, there's a lot of work for us to do. We got the approval. We had started doing the work. We laid the groundwork. And the cutover preparation and really getting the buy-in from, the hospital presidents, senior leadership, our nursing directors. People are scared of change. And I think that's one thing that we really like to do in our department is change things. We like to iterate. We like to make things happen. We're all engineers by nature. We want to make that change happen. And, we got that buy-in. We spent about 3 months, hiring staff. I would say, knock on wood, we filled every vacancy day one. We were ready to make that cut over. We were fully staffed when we made that change Friday to Monday. And, we officially cut over January 15th of this year. So we're about 10 months into the process now. I think it's been really exciting for us. We've cut over a lot of teams, a lot of work, and we'll continue to see kind of the dividends of that transition. Our next, strategic shift was building our diagnostic imaging team. I think it was one of the most important things that we've done in the past year. On top of, transitioning in-house, we also simultaneously built a diagnostic imaging team. It was a team of one for probably about 6 years for an organization our size because we were fully OEM, contracted. And the only thing that we were permitted to do was support end of life and to support systems. We only got to do what we had to do, and we started to gain a little bit of trust. We got a little bit of value out of that, but it was important for us to start to identify more work that we could do. So we said, hey, let's start to identify different opportunities by, moving to more first tier support, right? Can we move to first look contracts? And the immediate answers were, no, we're not going to let you guys do that. So again, through conversations, iterative over the past 12 to 18 months, we've been able to change, like clinical engineering, we're now a standardized service. We have those capabilities to do what you're looking for. Give us a chance. And after all that stakeholder buy-in, we finally got that chance in the past year. In the past 12 months, we went from 1 FTE to 6 FTEs on that team. And that was, without a lot of that groundwork, we would not have gotten that far. Our executive director of radiology has full support of our program. He is ready for us to jump in, dive in deeper. We do not get enough money to replace the equipment that we need to do every year. I think we ask for, tens of millions every day to replace imaging in our fixed fleet, and we get a small portion of that. So we're going to continue to have to manage that effectively over time. And I think, our primary goal is, we have a great diagnostic service manager, John Coot, if you know him. He's been pulled in to kind of manage this fleet on the day-to-day. He has become an integral part of that as well as the team. And we have a structure to actually bring folks in. We didn't even have diagnostic imaging job descriptions on our team before. And that took 9 fun months to get through. And we want to improve that, and we want to continue to grow. We want to make that work. And I think the other important thing for us to call out is we're basically a vendor for our department, but we also have matrixed, collaboration with techs at all of our sites, right? The system's too large. We can't be everywhere at once. We need to make sure that we're effectively supporting and addressing those needs, and make sure that our teams feel elevated to learn some imaging if they're not dedicated to the imaging team. So I think it's an important part for us to work through as well.
So transitioning from OEM contracts,
Mm-hmm.
how much cooperation do you get from acquiring training and all of this, especially retroactive, to have a system in place?
Yep.
And you're under contract.
I think there's two things there that's been our primary approach. We've been thankfully able to hire a lot of folks that have industry experience and have come in with that training, come in with that skill set, come in with a lot of that availability, which has been nice, right? Being able to say that we have the full support of our radiology teams, our heart and vascular services, that they're going to come in the door and be able to do their jobs was a huge sell, because a lot of them were partners in the space for us in the past, and they're like, we don't want to work there, we're not going to be able to do anything. And just being able to change that narrative for them and for those teams, I think has been important for us. I think the second thing we've done is, standardization is important to us. Standardization of equipment is important to us. So where we've been able to get that value back is if we're strategically aligned on a modality, right? We align that service need in with those agreements, right? So if we are going to purchase a fleet of ultrasounds, for example, or we're going to strategically align there, we're going to get that training built in, we're going to get that contract built in, and due to the volume that we kind of churn through, and I think we've been able to get that conversation going, right?
So it's basically a factor with the size of your operation that you can dictate.
Yeah, we definitely have a little bit to work with there, and I think that has definitely helped us. I think if we were on a smaller scale, that would be a tougher conversation. But I think with our ability to align and push standards and get our folks to buy in to say, this is what you should be doing for an ultrasound. This is the only choice for an MR. This is the only choice for this, that allows us to kind of work through that process. And quite honestly, it wouldn't be driven without our operational stakeholders also agreeing. They guardrail that for us and with us in partnership with us and say, this is the only decision you can make, and here's why, because clinical engineering needs to support the device.
Brian, how do you manage and handle, I would imagine between the 7 hospitals, they don't all have, or maybe they do, the same ammos and CTs, like you have some non-trained that you're still one-off when you need. How do you?
Yeah. I'd say we've definitely worked from the bottom up, right? Ultrasound, X-ray, fluoro, that's bread and butter right now. They're easy things to kind of churn out and really prove ourselves in. We haven't gotten into the big iron stuff yet. We've really started doing some of our procedural suites that may have fallen off a service contract, right? Now we are responsible for it. And if we get given that opportunity, instead of immediately jumping to the next, third-party group that may do it, if we have somebody on staff that can, please give us the chance. And I think that's helped change that narrative for a lot of our folks. Like, oh, this team can do that work. We should let them do more work. And I think that's where we're trying to take that opportunity as they present themselves. I'd say to a degree, they have home bases, but they are and are going to expect it to be more transient. So when we have a team of we have over 600 ultrasounds in the health system today. So when we go to approach that and we want to address that, we have a team of folks that are trained. They're going to need to travel a little bit to accomplish that job. And I think that's the expectation we set with our team. And it's also, cross training, right? It's going to be very important for us, right? We can't be everywhere at once. Maybe they need to travel for the PM, but if it's a quick remote fix that can be done or help over the phone, I think that's the expectation. And being able to systemize has allowed us to do that, right? If somebody in Greenwich has a call and they don't, the person is in Westerly, 110 miles away, they're not going to be able to get there very fast. But providing people with the skill sets to just support that thing over the phone is going to be an important part of this strategy when we do these vendor, internal vendor programs, if you will, for us. And again, I always hate to talk about dollars, but this is my favorite slide because I keep piping our teams on it every day. Since we were able to make this decision, we've reduced our imaging operating budget by almost $1 million in the past 4 quarters. It's a huge shift for us, and it's going to continue to get more effective, right? And I love a good quote, as Sam knows. So I think, this was a voicemail that was left to our boss, and it was actually presented in one of our leadership forums on our behalf. They said to us, for imaging, for a long time I didn't feel supported, and you've developed a team that has been able to support our patients here at YNHH, and I really didn't even know you guys existed. So I think hearing that messaging back to us and sharing that with our teams has been super important for us. Say, hey, what you guys are doing is working, what you're doing is effective, and we want more of it from you guys to help support our programs. And lastly, we wanted to build that ambulatorium as we talked over before. We have a complex web of business models: Northeast Medical Group, Yale Medicine, our hospital outpatient departments, Yale New Haven Health Urgent Care, our home health programs, our VNAs, et cetera, and none of them talk to each other. We're one of those few support services that really bridge that gap between them and really bring them together to, hey, let's talk about equipment. How do we address this need? How do we address this gap? I say over 100 plus, there's a lot of co-shared geography devices, going crazy today. Park Avenue Medical Center, for example, it's got 24 clinics in it. So we have a lot of shared space, a lot of geography, a lot of square footage that we're addressing across a very complex region. Lots of independent management groups that do not communicate, and we've really been the one that's really been able to find that collaboration with them, address their needs, address their services, and really support it across a very broad region. I call out our major concerns. Again, this is one of our lovely audits. We had a lack of SOPs in the space. Nobody knew who to call. Nobody knew how to address their support service in ambulatory. There was a lack of accountability to ownership. I mean, we candidly say we kind of accepted what was out there in the space when we both came on board in our leadership positions, and we weren't watching it, right? And so we took a more active role in watching it. We said, okay, well, we should really just take this and do it ourselves and make it better. There was an inaccurate inventory. I think we're still working through that today. I mean, it's a huge gap for us. I mean, I think both on an inpatient and an ambulatory perspective, considering our geography, lack of transparency, and a lack of KPIs. I think that's where we go next and elevate ourselves is, not only do you feel better, we're actually doing better, and here are the numbers to prove it. I think that's going to be a huge next step for us in this space. So again, we've brought this team together. We have a core service manager for our ambulatory team with 4 technicians that support the entirety of the enterprise right now. A lot of our more proximal offsite locations are supported by the hospitals themselves, right? Why send somebody 60 miles when it's a clinic across the street, for example, from our main hospital? And just finding that collaboration between all the teams, like, hey, I'm over here. Can you please go over here and help us out today? I think that's been a huge structure shift for us. We're aligning all the support between our varied structures. We still continue to have some third party in this space today, but they're entities that still operate wholly independently, even though a part of the organization. So I think those are on the roadmap for us to transition as well. Strengthening the relationships with a lot of leaders. A lot of those leaders are trying to figure that out right now. We're aligning, they call it our ambulatory enterprise, under a singular executive vice president over the next 12 to 18 months. And that's going to be an important part of a process that we want to be a part of. We want to be a stakeholder at the table for how are you going to address the needs for all of the business units that you kind of work through here today. And then really just managing expectations for us. We're never going to be the person that's there within 10 minutes. It's not possible in an ambulatory, especially in the geography of our size. And it's really important for us to figure out how we want to approach that with our teams. Yeah.
You said you're realigning, I guess, the operational side. It's going to be senior vice president of acute care.
Yep.
And so will they have their own CE support team? Will that remain part of your team?
We were more a part of our team. So it'll be operational executive vice president over all of the clinical enterprise for ambulatory services, assuming responsibilities from all of our delivery networks where they were centralized today, and having a single roll up for all of our prior business units, the urgent cares, Northeast Medical Group, Yale Medicine as well, which has been a university affiliate for its entirety. And a lot of those are creating dyad relationships between the university. We have the clinician enterprise that's being addressed right now within our organization is really aligning the university more effectively with the hospital side, because it's been another disconnect for us, right? We have a huge, a wealth of resources in our backyard that don't really transcend always, and then again, don't go the other way. And aligning that with us and ourselves, I mean, we do a lot of work with the academics in the area, collaborating and just making sure that we are a part of that process. I think is important for us.
But this team still report through?
Still through us, yes, correct.
With all these different business entities that you're supporting, how are you getting paid? How are you funding your program to be able to support that? Is it done centrally through program funding, or are you doing per hour or rated or flat rate billables within the intercompany?
So we are part of our corporate services entity. So each one of those business units pays a percentage into the corporate services. So ourselves, corporate supply chain, IT, legal services, risk services, they're all centralized for all of those operations. So each one of those pays a percentage into our corporate services to gain benefit from that, if you will. We do not do discrete cross-charging. We do not do billables. So we are just a part of a service structure for the entire organization.
Cleaner for you, right?
Yeah.
You don't need to worry about how much work you're doing for each one of
Correct.
those entities.
Yeah.
So essentially, it's kind of a pay to play. Right?
Correct.
Those specific entities,
Yep.
your
And that's where those,
pay your corporate
yeah.
services for program fees that they.
and that's where some of those exclusions come into play today. Like a Yale Medicine, for example, they don't pay into that structure. We do not currently support them. As we align the enterprise, it's likely that that could be a transition for us, but we're not trying to put the cart ahead of the horse, right? If we're not getting the staff, we're not garnering the support to actually do that. We don't want to get too far ahead in standardization where we're ahead of the organization, right? There's value in some situations. There's a lack of value in others for that for us.
Because you don't want to change your practices for a single entity.
Right.
I'll start working for you when you pay my sugar daddy.
Yeah.
Chocolate company.
Exactly.
So then, yeah, none of this would be possible without having those key service line partnerships, as you alluded to, because we all know in this room, the biggest threat to standardization is non-standardization in terms of our support, our capital planning, et cetera. So how do we fix that non-standardization issue? You follow the money, which goes back to our capital planning process, not only replacements, but our executive business planning, our system capital oversight committee, which does large construction renovation projects, those strategic initiatives. We're building a brand new neurosciences tower. That's where the money is. And that's where we get to help make some of those decisions. But again, that does not happen overnight, getting a seat at that table. And it really started with our service department. So we, as a leadership team, wanted to target those high impact areas and really start with those relationships. So we do have relationships, obviously, across all clinical service line partners, but really wanted to focus on where the money is. Diagnostic imaging, perioperative services, for Yale, our heart and vascular area like cath lab, EP, et cetera. And then finding radiation oncology, and then finding fellow gatekeepers in the standardization process to be our partners, which include facilities and supply chain. So we have regular cadence meetings. We have, those directors and vice presidents on speed dial for us that, if there's something coming in, they'll call us like, hey, did you hear about this? We're like, no, send us all the documentation, and vice versa. If we hear things, it's a bi-communicational direction. But again, starting small, building trust. So if there's an issue in the OR, if my OR technicians are not responsive, there's no chance anyone's going to trust me to then come in and do a capital plan for them. So it is, being responsive. So you start small. If I call you for help, you come, you respond, and you close the loop. Then you can kind of go on to the next level of collaboration. Hey, we have this very complex problem. Would you like to help us on this solution, as opposed to calling clinical engineering to the carpet and saying, why isn't this done? Why is this wrong? Why did this happen? Once you kind of get that responsiveness and the collaboration down, you can really then start to demonstrate your value. People will start asking you for your opinions. People will start asking you to help with things that's not necessarily clinical engineering. And I do strongly feel that we should not be doing jobs of other people who are not doing their jobs. But at some level, you do have to kind of make that helping hand. Like, I can't help you with this, but I will get you the person who can help you. And that's walking down to the on-site IT department, dragging the client desktop services technician up to the OR and looking at a problem together. It takes a lot of effort, a lot of time, but you really have to do this to not only build trust within your internal customers, but also get other support teams to work with you on issues instead of just transferring tickets to you, cold handoff, like that's clinical engineering, figure it out. And then they'll start to pull you in like, hey, clinical engineering, we have this issue, like, let's work on this together. And once that building block and the foundation is built, then you can look into proactive planning. And we go back to slide, Ryan. So a great example of that is our capital planning process. So historically, even 2-5 years look back, equipment would show up on the docks and they'd say clinical engineering, come check it out, and then we're going to install it. And it would be something non-standard, something we couldn't connect to our electronic medical records, something that the vendor doesn't train biomedical technicians on, that we have to have a super expensive point of sale service contract for. And that was really frustrating for our teams. So building that rapport, that trust, that structure, clinical engineering now has a seat at that table, and anywhere across the organization that capital can be purchased in, we have to approve it. Now, we don't always get to say no, that's the caveat, but there is a lot of times generated awareness and the ability to have that conversation. There may be a provider who's really dead set on this one very particular C-arm, but because we have supply chains buy-in, facilities buy-in, the executive business planning councils buy-in, our COOs buy-in that, this team can't support this specific C-arm, we can say no oftentimes, that you don't get to have this one-off unit. And clinical engineering saying that no alone doesn't carry a lot of weight, but if we get everyone else aligned with us, talking about different consumables that need to be supported, different facilities requirements that need to be supported, and if we're all aligned, it's a lot easier to say no. So similarly, like digital technology solutions, we have a great partnership because we roll up through our IT DTS organization, that if equipment comes in, we're reaching out like, hey, I think this needs a server. I think this connects to PACS. Like, can you look at this with me so that we have all the requirements up front, so that everything's approved and budgeted for, so that when it comes time to implementation, we're not missing, a $60,000 network infrastructure that nobody thought about, and vice versa. Anytime anyone from DTS is asked to review an application or something, they're like, hey, I think this connects to a medical device. Like, can you take a look at it? So we've built a lot of those really strong partnerships, and being able to have that seat at the table and facilitate those conversations, and really generate awareness for what our team does at a much higher level. And a really cool part of this is that we actually get a budget for capital planning. So there are a lot of groups that put together, they're kind of like systematic teams, but then we also proactively put plans together for large fleet replacements. So anesthesia machines, patient monitors, trigger word, intra-aortic balloon pumps, anything along those lines. We are putting a plan together and we're saying, okay, we're going to replace this hospital's anesthesia machines this year, this year, this year. We meet with those service line leaders and they buy in. They're like, yeah, we trust you guys, like roll with it, we're good. And then we actually get a budget from those capital committees to execute on our plan, which is a really cool thing. So not only do we get to review what other people are bringing forward, we're actually helping to drive our replacement plan and help our teams, right? If there are 30-year-old anesthesia machines out there, getting those replaced is our top priority, should be the clinical top priority, and then we get it replaced and we're able to effectively provide patient care and provide support. So it's a really cool thing. It's a really cool process that we've been able to execute, and then we also control similarly when the equipment comes in. We are in charge of all the invoicing that comes in. So who's approving? We don't have clinical units that sign off on, yeah, we received the equipment, but it turns out to be an out of the box failure. And then you're like backtracking, like, okay, how do we fix this? So yeah, and this again, not possible without creating that trust in the first place. Yes.
What benchmarks do you use to gauge how effective your capital?
Yeah, we do look a lot at ECRI in terms of pricing, et cetera. I mean, I will say we're probably similar in a boat to everybody else, way behind the benchmark on replacing capital equipment. We have a lot of old, outdated stuff. So right now we kind of really look internally. We have those replacement criteria that we pulled together. It is, based on a lot of, Vincent Wong's data and support on like what we should be focusing on, but we are still replacing systems that run on Windows NT. So
what's like the primary goal of capital?
Yeah, it's to replace. So we want to make sure that we have systems that are reliable. So anything that we look at serviceability and supportability. Can we get parts? Can we patch it? We also look at utilization and redundancy. So when we look at like high-end imaging planning, for example, we may not always replace the oldest equipment, but we do replace an equipment that has no backup within, a 25-mile radius. So if that goes down, those patients are getting diverted elsewhere. So there is a little bit of revenue, and again, that goes back to our clinical service line partners. Like, they have to help us with that information as well. Great question. So again, we're not perfect. We still have a long, long, long way to go. But what are we looking at next? I think from our perspective, really maintaining and continuing to develop that uniform care team experience. We do have a career ladder in biomed. We do have a career ladder in diagnostic imaging. Folks can transition between those two service line ladders, but what does that actually mean to be at that level? How do folks progress and develop and grow? Do we have a standard training plan? We really don't. And it's something that we're working to develop, as has been pointed out to us, that's a huge glaring gap in our program. While we have policies and procedures, we don't have a great way of onboarding folks and navigate them through following that process. So continuing to develop our teams and invest in our staff makes all of the rest of this possible. We're also looking at, speaking of, developing additional specialized service offerings similar to a diagnostic imaging team. There may be other areas of support where we can help. We do leverage, a couple of technicians who are specialized in intra-aortic balloon pumps, for example, that do cover our balloon pumps across the whole organization. That's not only cost effective from, a training perspective, but it also helps to develop that deep technical expertise in those people, as opposed to, a site that has balloon pumps, but they never get used. So like, that person doesn't get to continue to develop their skills. Whereas someone who sees the equipment day in, day out, they know what recalls are available, what's going on with it, can share their expertise, from afar as a first look, or, physically traveling on site. There's a whole lot of areas. Something that we're just starting to kind of really get into is lab, for example. There's a huge gap across our delivery networks. Some people do centrifuges, some of the lab stuff, the lab techs do the centrifuges, and they all do it differently. So as we try to systemize our team, we're also pushing other service lines to systemize their teams as well. People can't make those decisions in pockets. If there's a sleep lab in one location, they're looking to evaluate equipment. We say, what does your system sleep lab team say? And they're like, well, there isn't one. All right, well, you better create one then, because we're not approving this in a silo. When the other sleep labs come up for a replacement, they're going to get the same thing. So that's where that service line strategic partnerships that we're going to continue to strengthen, which ties back to our specialized services offering, which is based on our uniform care team. And then, of course, Ryan and I love the unknown. We love solving problems. We like working with our teams to solve those problems. We have a lot of great creative folks who come from a lot of different backgrounds. And that's why I love working in biomed. Everyone has a amazing perspective to share. So, I think we're ready for whatever the unknown is that comes our way, and we'll put it into a process and approve it. Yeah, so with that, we are absolutely happy to take any questions.